myself intrigued today to you guys that the virus that I have on my computer hides it. Yeah.
Professor watched too much porn.
Oh, okay. So I'm hoping that the virus I had was just hid my file as opposed to losing all of them.
Damn it, Tim.
All my tests.
Why I gotta be in front of the light?
So, I'm hoping that. Okay, so this is nursing management during the postpartum period. Okay, so I'll just explain this to you. So this is us taking care of the woman after she delivers, and what we're looking for. This is a time of adjustment. It's a time of physical and a psychological adjustment after the baby is born. Okay, the woman's body needs to adjust to its new state. It's now the placenta's out, the baby's out, and now she has to. The uterus has to start to try to get back to its old position that it was in. The family has to adjust to new roles. Social support for the new family is important, especially if you're a new mom. It's nice to have family members around to help you out. Okay? It can be stressful. Nurses play an important role as a mentor, educator, and a resource person. And nurses need to be culturally competent in caring for the woman and her family. So you'll see in the chapter, I'm not sure if it's 15 or 16, one of those chapters discusses cultural things that different cultures believe in after the birth of the baby. So that you can use that as a source also for that pamphlet of yours, okay? And so as a nurse, you'll see, how many people got a chance to like follow nurses around or see how they work and stuff like that? Okay, did you see how they do a lot of patient education? Were you noticing that? Like compared to med-surg, what would you say the difference? Can you see the difference between med-surg nurses and maternity nurses? The job, it seems like, and again, every place in life might be a little bit different, but it seems like that the RNs in medical surgical floors, the job is mainly giving out pills and medications and contacting the physician. Where the nurses in OB do a lot of teaching, particularly the new moms, so many questions. Also the moms who are breastfeeding for the first time, they have lactation consultants, all that, because they have so many questions. I talked to Amy at Valley Education, Harvard Education and General Education. She she had emailed me yesterday saying that students are calling, and she wanted to let you know that she only wants to take one student each class, so those who want to go to Valley. Did you realize that? The other thing she told me, and this involves everybody, because people who haven't said can go to Valley also, it's like, or wherever you can go. But this woman I spoke to today from Valley, she told me that they have a class a couple times a month in the evening from 7:30 till 10 in breastfeeding. The breastfeeding class when mothers were pregnant. She was encouraging me to have the students go to a breastfeeding class, so that you're familiar with it. So my thought is that I could give you. I might save this again if we do have a snow day or something like that. I can have you go to the breastfeeding class as a makeup time for a snow day, okay, or whatever kind of day that we're closed. But she's encouraging students to come. It's free. It's as I said, 2.5 hours. It's either a Wednesday or a Thursday night. She told me to go to the website for Valley Hospital and go to education, family education, and we'll be able to see what time and all that. But she wants she says, let her know, she wants me to let her know if students want to go to this and when they want to go. So this way I have a connection with her. But I'd like to go to that class too. Because I'm thinking to myself,
It's different again.
I don't have time really that much time to work with the breastfeeding. would be interesting to do, you know. So that's just something she told me today when I spoke to her. Nursing management is important to assess the woman's ability to adapt both physiologically and psychologically. Based on your assessment findings, the nurse is able to plan and implement care in order of the priorities of the needs of the patient. So, you know, if you go into a room where a patient has C-section, the priority need might be pain, right? You have somebody with vaginal delivery, she might have pain, or she might have questions about breastfeeding, you know, that she's not unsure of. So really it depends on the person. It also depends on the last time they had a baby and if they breastfed before or not. They're really, really trying to encourage breastfeeding at that. In fact, they used to have, this is the last year we retired, they used to have these cute packets from Similac or Infamil. Okay, companies would come and they'd have these little cute bags, like diaper bags, and they put all sorts of formula and, you know, bottles, free bag for the mother to take home with her, okay? But now they don't have them anymore. When I came in this week, last week was like, where are those, you know, Infamil samples and stuff like that? Because we're so hard in trying to get people to breastfeed, we decided not to give them the bottles anymore, you know. Which again, I don't know. I think it's a personal decision, really, but anyway, it's just sort of interesting what they're trying to do. Okay. Let's see. So we have to keep in mind any kind of risk factors that may lead to complications with the mother. The nurse should be aware of postpartum danger signs, and this is from the second edition, but here's some of them. Let's go back. Right, here's some of the danger signs to be aware of, okay? Factors increasing the woman's risk of postpartum complications. So again, as a student nurse, I know it's all new to you, but some of the things you could be aware of that might be something that could happen in the future. If the patient had operative procedures such as forceps or cesarean section or vacuum extraction, they are at risk for hemorrhaging. The baby with a vacuum, or they don't do forceps anymore, pretty much. But a baby with a vacuum extraction, sometimes they get something called a hematoma on their heads, where it's like a bleeding between the scalp and the skull of the baby. The mom is at risk for being, you know, having a tear because, again, they put in something wider into her, not really that. And then infection, so she's at risk for that. Okay.
I'm sorry. Are these slides the same as the one posted online?
No, I think I might have mentioned. I lost all my slides, my computer.
So it won't be the same. No, just making.
No, I know, no. I don't remember what I put on for you because I can't get them. So I'm going on to what I have for 16. Okay? Because all my files are gone. So the only files that I do have are the ones on the desktop. So this is from the book. Okay, it's from the textbook. All right. Also, people with a history of diabetes, including gestational onset of diabetes, again, they are at risk for continuing diabetes, and also at risk for infection. Okay. Prolonged labor, more than 24 hours, again, they're at risk for a hemorrhage and infection. Use of an indwelling catheter, they are at risk for urinary tract infections, anemias if the hemoglobin is less than 10.5, multiple vaginal examinations during the labor process. So if the doctor keeps going in like this, what is he doing? He's bringing bacteria up into the uterus, so they're at risk for infection. And then, of course, prolonged rupture of membranes, more than 24 hours, what are they at risk for? Okay, and then a manual extraction of the placenta, that's if the physician or midwife is pulling the placenta out. Sometimes that can cause bleeding, sometimes it even can cause the uterus to turn inside out and then start hemorrhaging. So that's something also. A person who is compromised in the immune system, HIV positive, again, more the risk of, and a slight risk that the newborn can have it. It's really not as much as it used to be. You know, it used to be like 2%, but now with all the drugs out there, it's less than that. Okay, and again, they're compromised, so they're more at risk of infections. Risk factors for postpartum hemorrhage. Okay, precipitous labor. What does that mean? It means a really quick labor and delivery. Okay, less than 3 hours. So again, that will put them at risk for hemorrhage. Uterectomy. Okay, again, that's the number one cause of postpartum bleeding. Like I said. Did I say that? Yeah, it must be on the next slide. Okay, the number one cause of postpartum bleeding immediately after delivery. For several days. Okay, placenta previa or rupture of placenta, that's something we'll talk about at some other point in time. If the woman is induced or augmented, okay, that means that she's also at risk for hemorrhage. Operated procedure that was hemorrhage, retained placenta fragments. Retained placenta fragments are, if you look at the placenta when it comes out, you see the doctor examining it, making sure it looks whole and not, pieces missing from it. If some of the placenta remains inside the uterus, she's at risk for a hemorrhage because what will happen is her uterus will keep contracting, trying to get rid of that placenta that's inside of her. So what will happen is she'll try to bleed it out, and she could hemorrhage by doing that. Sometimes they'll bring the patient back in, and we'll scrape out the uterine lining to get that placenta out so she doesn't hemorrhage. Okay. All right. A prolonged third stage of labor, if it's more than 30 minutes. Multiparity, more than 3 births closely spaced. Uterine overdistension, so if she has a large baby or has twins or has something called hydramnios, which means too much amniotic fluid, she's at risk for a hemorrhage. I know, I had class this weekend. And I didn't feel, especially after having a class and after having a test. Your brain's not all there, right? Oh, it's not. Okay. And then we have here, down here. Postpartum danger signs, including, and this is on that same slide, when a woman delivers, okay, for the most part, a lot of times she hasn't had anything to drink or eat for a while. Okay, it could be 24 hours, it could be less, but she might be dehydrated. Okay, so what happens is if she has a temperature of 100.4, not 100.4, 100.4 and lower in the first 24 hours, they will say she's probably dehydrated. She doesn't have an infection. Okay, so what would you do if she's dehydrated? Keep offering her fluids. Okay, maybe she still has an IV in, so that's important. After the first 24 hours, if she has a fever of 100.4 or greater, that means that she has an infection. Okay, so the first 24 hours she can have a temperature that up to 100.4 because she's dehydrated. After that, it could be an infection. Okay? If she has foul smelling lochia or an unexpected change in color or amount of her lochia, that could mean she has an infection, or again, she could be hemorrhaging. Okay? Visual changes such as blurred vision or spots before her eyes or headaches can mean that her blood pressure is going up. Calf pain with a dorsiflexion of the foot, the Homan sign, could indicate that she has a thrombosis. Swelling, redness, or discharge at the episiotomy site can be that she is experiencing an infection. Dysuria, which is painful urination, burning, or incomplete emptying of the bladder, could mean that she has a urinary tract infection. Shortness of breath or difficulty breathing could be something called a pulmonary embolism. Okay, so that's a very serious condition. And then depression or extreme mood swings after delivery can be a sign that she might be suffering from postpartum depression. So what do we do after the woman delivers? We talked about this a little bit. We talked about baby delivery. Monitor the woman after delivery. Assess her every 15 minutes for the first hour after delivery. 30 minutes for the second hour, hourly for 2 hours, and then every 4 hours that first day. After that, it's just once a shift. Unless there's a problem that gets picked up before, she's only once a shift. You monitor for any complications. You monitor for lochia, for the amount, the color, and odor. Monitor for bladder for odor distension due to postpartum diuresis. After they deliver, they pee a lot. Okay, the body's trying to get rid of the fluid, so this is diuresis that they have. Okay, the vital signs you wear. Temperature slight elevation during the first 24 hours. That is normal, remember I said that already. Her pulse will be a little bit of bradycardia. Okay, so you have to know this too. It's like, what do you expect after she delivers? Her temperature can go up to 100.4 for the first 24 hours, but after that, infection. Her pulse will have a little bit of bradycardia, so if she was normally 75 beats per minute, she might be 65 or 68 or something. And that, again, will last for about 10 days. Her respiration should still be within normal range, okay? Her blood pressure usually will stay within normal range. And her goal, really, for her pain scale is 0 to 2. So that's the goal. As we know, when we talk to different patients, when we go to different rooms to talk to patients, we'll say it's a 6 or it's a 5. If I lay here, it's a 2. When I get up, it's a, So they will give you an indication as to pain medication. But once you find out that her pain level is above 2, okay, you have to do something about it. Because you're going to, if you're a nurse charting it down, her pain level was a 5, then the next thing is they're going to say, well, what did you do about it? Okay? So you either offer her medication or Tibanum, ice pack, or 6-bath, or whatever, but you have to say you did something about it, and then you follow it up again to see what her pain, reassessing her pain level. Okay? We talked about the vital signs. The following statement true or false. During the first 24 hours postpartum, a slight elevation in temperature is considered normal. Right. Dehydration. Okay. And if I can get these slides over to your blackboard, I'll send them. Okay. So you have more of the details of the slides. Again, this is the bubble key kind of assessment of the woman. We're going to inspect the breast for consistency, if they're soft versus firm versus hard. I saw an NCLEX review question, and I was surprised at how many students got it wrong, but again, maybe I didn't teach you, okay? So the question was, when the woman first delivers her baby, her breast would be, what do you think, soft, firm, or hard? Soft, yeah, because her milk is not coming in. So that was one of the questions. What do you expect when you assess her breast, like within 24 hours after delivery? Soft. The milk doesn't start to come in until day 2 or 3, and then it starts to get firm, and then she might get hard breast if she's not being able to remove the milk from her breast. You also want to check the nipples for cracking, redness, bleeding. This can indicate that the baby's not feeding in the correct position. And this you can see almost day 2, okay? Day 1, the baby sleeps and feeds a little bit, sleeps and feeds a little bit. But on day 2, the baby becomes a little bit more vigorous in feeding. And you'll hear people say, oh, my breasts are getting a little sore. So they offer this lanolin cream that they can give the patient. So, that's something that can be done. The baby can change positions because the baby shouldn't be on the same nipple for the whole time, Okay. Also note if the nipples are flat or inverted, this can make breastfeeding more difficult. In that case, you usually will have a lactation consultant come in, and maybe there's a breast shield or something to do to try to get the nipples more erect. Localized area of pain and warmth may indicate an infection in the breast called mastitis. Mastitis is usually not seen until the woman goes home 2 weeks later after she goes home. After delivering the baby, she could get a condition called mastitis, which is an infection in the breast. It could be because she has a cracked nipple and maybe bacteria got into the breast. Okay? But they put her on antibiotics, and believe it or not, they encourage her to keep breastfeeding because she's on antibiotics, and they don't feel the baby's going to get anything. And the best thing to get rid of this mastitis is to empty your breast, which is breastfeeding recovery. Okay. The uterus is set to be fundus to see if it's involuting. Remember, involution means that it's going to go down 1 finger breath a day. Okay. Sub-involution means it's not going down each day. Okay? Have the woman void prior to assessing the fundus. The fundus should be midline and firm and descend at a rate of approximately 1 centimeter or 1 finger breath per day. Day 1, 1 centimeter below the umbilicus is reported as U minus 1. So umbilicus minus 1. Okay. 1 centimeter. If the uterus is boggy or relaxed, you would indicate that there's uterine atony, okay? And having a full bladder can cause the atony to occur because the bladder is right underneath the uterus, okay? So what happens is if it gets full, she doesn't realize it, the uterus will be misplaced and won't be able to contract really well. So a full bladder can cause this, so you want to empty her bladder. If she does have a full bladder, it's usually felt above the umbilicus and more towards the right side of her body. Having retained placental pieces can also cause uterine atony. Okay, so here you see the person doing the exam. The lower part of the lower hand would be the symphysis pubis or the bottom of the uterus. The top is at the fundus level. Conditions. Immediately postpartum bladder is edematous and hypotonic. What's hypotonic mean? Was it?
Yeah, we just learned this.
Hypotonic?
More
electrolytes
more electrolytes than
When I say
extracellular.
when we talk about pitocin, one of the side effects is hypertonicity. Means that the uterus is, really hard and tight, and contractions are coming. Frequently. And then hypo is the opposite. Okay. The bladder is edematous and hypotonic due to labor. The woman will have diffuse diuresis and greater than 3,000 mLs a day, so she'll be urinating a lot. She'll be perspiring a lot after she delivers. Her body's way of getting rid of is like more than 50% more plasma in the body when she's pregnant. Okay. So now she's not pregnant anymore, you gotta get rid of this stuff. So she's gonna be urinating frequently, and and large amounts, and she will wake up in the middle of the night all sweaty. And need to change her gown because again, the way the body gets rid of this is urinating and perspiring. Okay. Problems if there's a urinary distension or incomplete emptying, pain with urination. Full bladder causes the uterus not to contract, which can result in post-oral hemorrhage or heavy bleeding. Management, early ambulation, okay, void within 4 to 6 hours after birth. Now, at Valley Hospital, they say they want you to void within 6 hours after birth. Okay. If you had a C-section, cesarean section, they will take your Foley catheter out like 18 to 24 hours after you deliver. But after that Foley catheter comes out, they also want you to deliver within 6 hours. Okay, so they don't want the bladder to get too full. Okay. Let's see, management, early ambulation, void, 4 to 6 hours after birth, using nursing tricks to stimulate voiding, evaluate for signs and symptoms of urinary tract infection, burning, or severe frequency. The symptoms of UTI. Now, some of the things that, little tricks that they talk about, it's just like leaving the woman alone in the bathroom and let the water and the faucet run, Have her bring something in to read so she's not focusing on having to urinate. So maybe if you change your focus from like, I have to pee, but I can't, her muscles will relax. Okay, so there's some of the things that can be done. Sometimes they'll say to take that water bottle, that Perry bottle that you bring in, and you fill it with warm water, is to squirt it on her thighs. Sometimes that will relax her too. So those are some of the things that we can do. Bowels, lack of food in labor, dehydration, decreased muscle tone, perhaps even hemorrhoids. This could contribute to constipation. Okay? So usually what they will do is give the woman a stool softener, anti-gas for people who had a cesarean section. You want to auscultate for bowel sounds in all 4 quadrants. So near the C-section, it might be a little sluggish for bowel sounds the first day, but she has many things to eat. Ask the woman if she's passing gas or if she's had a bowel movement, so that means things are moving. It's not like anything not being able to move. Most healthcare providers will offer a stool softener at bedtime for the woman who is postpartum. Again, assessing the lochia, we're going to look for color, amount, odor, if there's any. Ask the woman how many pads she has used in the past 1 to 2 hours. Were they saturated? Or any large clots or odor? Large clots could really mean you need a placenta. Piece of placenta still in there. Okay, so you look for that. We used to say if it's an oversized quarter. We used to do weird things back in my day. We used to, if we saw a clot on the pad, we would try to break it up. You know, with gloves, not with with gloves, we try to break it up. If it didn't break up, the clot, we would think it's part of the placenta, because the placenta was sort of thrown together. And we used to sort of look at clots that were bigger than the size of the quarter. Okay. Bowel odor may indicate infection. Large clots may indicate poor uterine involution. So just the body, the uterus is not going back to what it was. A lochia flow will increase when the woman gets out of bed. Okay, so think about the woman with a C-section, right? She's lying like this for 24 hours. Right? She's bleeding, but she's flat like that. Okay. So what's going on? Her lochia is being cooled in the vagina, right? So when she gets up for the first time, what happens? It comes pour again her legs. Okay. So that's something to be aware of, so it doesn't scare you or the patient. Knowing that getting the person up for the first time, particularly C-section, who's been laying flat for 24 hours, it's not unusual to see them cooling. Gravity will take the place, and it might start coming down her legs. You know, so just be aware of that. And I always say, don't let her wear her fancy Christian Dior slippers the first day. Let her wear those ugly hospital socks, because she might ruin her slippers the first day just from the blood. Okay, so something to be aware of. Also, when the woman breastfeeds, this causes the uterus to contract also. Yeah.
In regards to blood lochia flow.
What was that?
When the patient gets up and you're expecting the lochia flow, you're not going to have like an increase in blood pressure.
Probably not. No, probably not, because it's just been there. Like, wasn't like, you know what I'm saying, it's just there overnight. So it's not like just hemorrhaging or anything. It's just, you know, in the vagina and comes, just come down her legs. You know, but you keep an eye on it. You know what I'm saying? You want to make sure that when she goes to the bathroom and gets back into bed and changes the pad, that she doesn't continue to, saturate the pads. Let me see. The woman should not saturate a pad every 30 to 60 minutes, because that can be a sign of hemorrhage. Oh yeah, I always love this. Whose pictures of it? I don't have it. And I've never taken out a measuring tape for this, all right? Description of lochia. Scant lochia is 1 to 2 inch amount of lochia on the peripad. Light or small amount is approximately 4 inches. Moderate is 4 to 6 inches on the peripad, and large or heavy amount is a pad that saturates within an hour. If excessive bleeding occurs, the first step you would want to do is massage the foggy uterus. It's a test question. Priority setting. Okay? So she has heavy bleeding. You would go in, feel for the uterus. You may not feel it, but you want to massage the uterus so it gets firm under your hand. Okay? Not over massage it because then it can make it relax again. And you want to document what you've done. And then you go back and check on her frequently. Okay, episiotomy and the perineum. You want to assess the woman, place the woman on her side with her top leg flexed at the knee. Take a pen light and wearing gloves, and you inspect her episiotomy site for redness, ecchymosis, tenderness, hematoma, hemorrhoids. You might see hemorrhoids in her rectum area. Not unusual for the first couple of days that the area does look swollen because she has been, she's gave birth. Okay, it might even be bruised. Healing will take place within 2 weeks. Sometimes it takes up to 6 months for it to heal. Okay, it depends on the incision. So just to be aware of that when you are assessing the woman. So let me ask you this: how many people know what supine position means? Okay, so you lay on your spine, supine on your spine. Okay, so does everybody know what Trendelenburg means? Your
Legs up.
yeah, okay, so your head's down and your butt is up. Lithotomy position, so you know what that means. Okay, that was on the test. That is when a woman goes to the gynecologist, they put her legs in stirrups to do an assessment on her vaginal area. That's lithotomy position. Okay, so this is saying the person should be delivering on lithotomy, should be the first stage of labor on lithotomy position. That means complicated come down. Okay. So I just wanted to go over those terms with you to make sure you understand it. Okay. Inspecting episiotomy again for what we just said. Not usually, usually a bruise. It takes up to 2 weeks, but sometimes people are even more than that. The lacerations we spoke about the last time. The first degree involves only the skin. The second degree extends to the perineal muscles. Third degree extends to the anal sphincter, and fourth continues to the rectal wall. Other things that you're going to assess the perineum at least every 8 hours. So after the first 24 hours, each shift, usually in the beginning of the shift, the nurse wants to get her work done so that she can chart, on the computer later. So the first thing they usually do is go in and assess the woman right off the bat in the beginning of the shift. You're going to look at for like hematomas, which sometimes are hidden in the vaginal canal. Or it would be large areas of swollen bluish skin with complaints of severe pain in the perineal area. So sometimes you can't see it, sometimes you might see it. It is like a blue little bubble that is a hematoma that might be painful for the patient. Okay. Perineal hematoma and severe pain, intractable pain, is discoloration of the perineum and ecchymosis. Everybody know what ecchymosis means?
Bruising.
Infection, redness or white line, the length of the episiotomy, swelling, discomfort, and perioral bleeding. Okay. All of the above findings need to be reported to the healthcare provider. Extremities. The woman, when she's pregnant, she's in a hypercoagulation state. Okay. So she does have she'll have an increase in the different things that cause her to clot. So she's like that while she's pregnant. The theory behind that is sort of nature's way of preventing her from hemorrhaging. So she stays in a hypercoagulation state after she delivers. Okay. But this state can increase the risk of thromboembolism disorder during pregnancy and postpartum. Several factors associated with pregnancy can predispose the woman to a clot formation. Stasis from compression of large veins because the big uterus that's pregnant alters coagulation, and damage may occur during birth. Signs and symptoms are lower extremity tightness or aching with ambulating, which is relieved with elevation and rest of the leg. Okay? And edema in the leg is usually, believe it or not, you'll have to take an eye, look at this. Usually when you find edema in the leg, it's more prominent on the left side. Okay? And again, it could be just the way the organs are positioned and where the uterus is putting more pressure on. So it's usually the left side. You want to also inspect for warmth redness and tenderness. Okay? To diagnose a blood clot, they would do a Doppler ultrasound, okay, and an ultrasound just to see if they could see a blood clot there. Okay. Sometimes they'll say for women who are at risk for this is to wear anti-embolism stockings, or we use those sequential compression devices, the little things they put on the leg after they deliver, okay, for 24 hours. Okay. And you want to encourage the woman to walk around. Now, sometimes what happens is people might have, like my cousin's wife was a skier, and then she had a fall and fractured her leg. But she ended up having a blood clot there, okay? And they picked that up right away. And then a year later when she got pregnant, because she has a history of having a blood clot already in her past, they put her on heparin the whole pregnancy to prevent the blood clot. Okay? So anybody who might have a history of having blood clots, they might put them on heparin. Sometimes they'll just put them on aspirin. But heparin doesn't, it's a large molecule, it doesn't pass through the fetus. So that's why they like heparin better than anything else. Okay? But if you're predisposed to blood clots, they will be following you closely. The Homan sign, you want to assess for the thrombophlebitis. Now again, you'll see that some of the doctors will come up with saying, do not do the Homan sign on medication. Some people believe if you do the Homan sign, you're going to cause the clot to be released. So some doctors will say, don't do the Homan sign. Some wouldn't say that, but it's just, usually there's a written note about it. Okay, so the Homan sign, legs stretched straight with knees flexed, sharply dorsiflex the foot. Pain indicates positive Homan sign, which needs to be reported. Homan signs is a controversial practice when it's dislodged clot. Ultrasound is done if there is a positive Homan sign, and treatment is low dose heparin. Okay, so this is somebody doing the Homan sign. You see how they have their hand under her knee, and the knees relax, and then they take the foot and dorsiflex. It means going towards the head. Okay, dorsiflexing the foot and assessing for any pain, redness, warmth. Okay, nursing management postpartum. Bonding and attachments and transition to parenthood. Again, this is important. It's interesting, like different points in time, they really, probably in the 50s and 60s, as soon as the baby's born, they whip the baby out and put it into the newborn nursery, and then mother got to sleep for 24 hours without even looking at the baby, Now they're so into the bonding, even when my daughter was born 29 years ago, they really were like, oh, you gotta bond, you gotta bond. You have to have rooming in. Everybody know what rooming in means? That the baby stays in your room the whole time. Okay. So they were encouraging this 29 years ago when I had my first daughter. And when you hear something good news, she's moving out. My daughter's moving out. March 1st, she got an apartment in Westwood. I've been trying to kick her out for 29 years now.
Girls, where we go. Hey, that's like, when there's some good news, Candace moving back in. Who I'm trying to get them in for 20 years. Stayed home for 20 years.
I don't have time for your mess, but I keep saying March 1st is coming right up this week.
Ain't nobody got time for that. Oh.
She has a boyfriend. She had him start to live in my house, and he brought his dog with him. Oh no! Not even asking me. So, can you picture that? Also, when he shows up, he's sort of, what was that? Well, I threatened everything. On the weekend. And all of a sudden they found a place in Westwood. Who takes dogs? Yay! Okay.
Congratulations.
Okay. So, the bonding is important, attachment is important. there's a transition into parenthood, factors affecting attachment, parents' background, infant care practices. Also, the age of the parents. Sometimes, if you have a woman like in her 40s having her first baby, she's so used to having her own life for 40 years. You know what I'm saying? So sometimes the adjustment is difficult because you're not, you've been independent and doing what you want to do, and sometimes at an age really, when you're used to being an independent person or a couple, sometimes having a baby, there's an adjustment.
Baby blues.
Okay, critical attributes of attachment, proximity to the baby, reciprocity, if the baby smiles or coos, or they can see your face. Commitment. There's a negative and positive attachment behaviors. The term proximity is the enduring nature of the attachment relationship, the parental role of exploration. So proximity is having something close to you, So a lot of times you see, the moms and dads, holding the baby. We had somebody last week, there was a couple, remember when the father of the baby was trying to change the diaper and change the diaper? It was sort of cute, you know what I'm saying? Like he was determined to change this baby's diaper, and he's like saying to his wife, no, that's too tight. No, that's too loose. And he kept undoing and doing, so waiting for the straps to not be able to, stuck together anymore. But it was cute to see it. Reciprocity is the physical and psychological experience of the parents being close to the baby. Again, somebody had told me nature's way. I love these things about nature's way, like the body and all that stuff. It said that babies, they cry, they're up every 2 hours to every 3 hours at night. You got to feed them, breastfeeding, that can take an hour, and then 2 hours later, the baby's up. You're exhausted, totally wiped out. And about 8 weeks, you just got had it, and all of a sudden the baby starts to smile. And you're like, oh, it's like, it's so worth it after that, you know what I'm saying? It's just nature's way of when you're really exhausted and can't think anymore, all of a sudden they put on a smile. And then you're like, all in love with them again. Okay, and then commitment, the enduring nature of the attachment, the parents' role are committed to caring for this baby. Let's see, okay, so again, you want to make sure that you're doing culturally sensitive care. Promote comfort. The first 24 hours, someone gets an ice pack, right? That's something that's always on the test. The first 24 hours, it's an ice pack. Off the perineum. If she's a C-section patient, she might have the hemorrhoid to, you might want to offer her something, but for vaginal delivery, the first 24 hours, you offer an ice pack on for 20 minutes and off for like 20 to 30 minutes, on and off. Okay. And this decreases swelling and it also numbs the area for the woman. So those are some of the good things about it. Heat application is done after 24 hours. Okay, so the first 24 hours cold, then heat 24 hours later and more. You can offer something called a sitz bath. Okay, the sitz bath is just, which what it sounds like, it's a little basin. I'm just pretty sure of it. There she is. There she is. It's, if you can see, it's a little pink thing that's on the toilet there, and it's like almost looks like a bedpan with kids to it. Okay, so what happens is, see the bag up behind her. Okay? You fill that bag with warm water. You fill the sitz bath with warm water, and she just sits there. Okay, it supposedly brings warmth to the area, causing the blood to try to heal the area. Okay, so she could do this 3 or 4 times a day, 10 to 15 minutes each time. Okay, and she can take it home with her. Okay. Other things to keep the woman comfortable, topical preparations, and we talked a little bit about that. They have a Dermaplast spray that numbs the area. They have Anusol ointment for the area that's painful. They have witch hazel pads, or sometimes they're called cups. Sometimes they're called Preparation H. Okay, and again, this is something that will soothe the area and hopefully help to reduce the swelling. And then again, they usually will have orders for the patient. Some doctors will say if she has a pain level of 1 to 3, give her Tylenol, or give her Motrin. You know, each doctor's different. If she has a pain level from, 4 to 6, give her 1 Percocet. If it's, 7 to 10, give her 2 Percocet. So sometimes you'll see the orders that it's written, depending on her pain level, what should be given to the patient and what she's allergic to also. Okay. Assisting with elimination, avoiding. If she's not feeling the urge to avoid, try to get her out of bed every couple hours. And then from that, promote bowel elimination again. Drink lots of fluids, fiber, and take those supplements. Again, this is a 6 bath, 20 minutes. The ice bath is the first 24 hours, on 20 minutes, off 10 to 20 minutes for the first 24 hours. And then the 6 bath is after that. You can also do the topical medication. The peri bottle with warm water to cleanse the perineum after voiding or bowel movement. How many people have seen those peri bottles? Okay, so they're nothing fancy. All you do is fill it with warm water. Okay. If her urine is still being measured with, with those hats, it's the first 2 times she voids. That's what Valley wants you to do, is measure it. Sometimes a woman will take that peri bottle and squirt herself to clean herself, and that will also go in that hat. So it's a good idea when you put the water into the bottle. They do have in mLs, 240. They'll have the highest amount of mLs in there, and you see that it's 240, and then she voids and squirts herself. You sort of take into account how much she squirted herself, because that would be part of her urination. It would be part of some other stuff. So you do it that way. They're really into IMO, whatever reason. Okay, she wipes herself from front to back. She applies perineal pad from front to back, and we use standard proportions. Okay, pain is assessed along with all the other vital signs, the type of pain, the location, the severity. And again, this is talking about, if she has mild pain, like 1 to 3, they do ibuprofen, mild pain. They might do codeine, oxycontin, aspirin, unit. And all these meds do go through the breast milk. Because moms will ask me that, does it go through the breast milk? And I said, yes, make the baby sleepy. So usually, a lot of times a woman will feel pain, that afterbirth pain, which means she's feeling contractions after the baby is born. That's because the baby was maybe too big, like the 11 pound that woman's going to have afterbirth pain. Okay. So every time the mom breastfeeds, she will feel contractions pain. Okay. So I usually say to the mom, take your pain medicine right before the baby is going to breastfeed. And then by the time it gets into your system, the baby's already finished breastfeeding. So that's one way to do it. Promoting activity, rest, and exercise. Of course, early ambulation is important. A lot of times, the women with C-section, they do give them 18 to 24 hours to get out of bed. A lot of times, they can't wait to get out of bed because they've been there for 24 hours. The sacral area starts to get painful for them. So they're just delighted just to be able to get up and get out of the bed and into a chair. Okay. Rest periods. Now, Valley Hospital, because it's so family friendly, they stated a policy of quiet time. Okay, and the quiet time is from 1 to 3:30. So from 1 to 3:30, lights are dim on the floor.
Why touch me?
And they
Why
try
don't you
to
touch
talk
me?
with no visitors. And they'll let the mom either take a nap or rest. And really, we're not allowed to go into the room unless she needs something, or we have to follow up on something. But it's a nice way for the mother to have time to relax and take care of herself without having 50 visitors in the room. Okay. Insurance safety, that is on page 436 in the second edition. There's a box that says insurance safety, so let's see what it is in the new book. Counseling about sexuality and contraception. I have to tell you, I usually don't counsel about it. Well, as a nurse practitioner, I do, but not as a nurse on the floor about contraception. We usually say, talk to your doctor or whatever. But again, it's really, it depends on the woman's breastfeeding or not. Depends on, if she wants diaphragm, supposed to be fitted for it. So, okay, safety. Check the woman's blood pressure before she ambulates and find, before you come up with this. Okay. And think about it. Again, she hasn't eaten, she hasn't drank anything, or very little. She never maybe 24 hours. She lost anywhere from 500 to 1,000 of blood. So getting her out of bed is something you want to do really slowly. Sit her up, as she feels dizzy. Okay. And sit there and bend her feet. Get her to stand next to the bed, right next to the bed, and you walk with her right behind her, and she will hold you. Not like holding her, you go on her arm, and every step she takes, because we do have a tendency, usually once a semester happens, where someone passes out, just because of, stuff. You want to take your time, with the patient. Resuming sexuality, they usually say sexuality, of course, once the sexuality is healed and the loneliness level stops. That can be anywhere from 4 to 6 weeks. I did have a funny situation, and my students were in with me, This woman just had her first baby, and she was in vitro, right? And she's all hooked up, she just had C-section. She still has her IV going, she just came over to the floor. There's a Foley catheter, an IV, dressing across her belly. And the first thing she says to us when she gets out of the delivery room was, when can I have sex again? I'm like, what? So here she's all incisions and IVs and Foley catheter, and she's like, no. Although when I just got out of nursing school, 100 years ago, I was working with Washington University, Washington, D.C. And we had, back then it wasn't a private room, we shared room, there was one was like a ward, there was like 4 patients in the room, and there I am, I'm hanging out the evening shift, and I go, I say, yes, she's a young girl. Undo the curtain. Her boyfriend's been popping for having sex. Wow. Right after she delivered. That just seemed really silly, but that was so shocking to me. Yeah. I didn't know what to do. I was shocked. So I talked to my instructor. I don't expect something. And I was like, I'm just out of school. And I was like,
the thirst is real. Huh? The thirst is real. What? The thirst is real. Thirst? It's his wife. Got that Loki acting on the room. Got that mushy ass feeling.
Remember, the woman is breastfeeding. She has low levels of estrogen. Okay? She's breastfeeding, and she has higher levels of milk production. So her estrogen levels are low. The estrogen is the thing that makes the vaginal area moist. Okay? If you're a woman breastfeeding, and she can have something called dyspareunia, which means painful intercourse. Okay? She's not lubricating because she doesn't have enough estrogen.
Huh.
So they usually will say that you use the water solution lubricant. Okay, that's one way. And this is it. If she is breastfeeding, okay, and she uses water solid lubricant, I don't know if that's a good area, she should breastfeed prior to intercourse because if she has an orgasm, milk will start spitting out of it.
Nice.
She's breastfeeding. It seems like complicated whole thing, right?
That's for female.
A night weekend? That will Kevin nap.
Is that what you think that might inhibit
Tell me about the
body unattractive, sleep deprivation, physiological responses.
Checking on Square Nut Dunkin' Donuts coffee.
Lighted sweet coffee.
Oh,
Okay, now you go over what?
What's the name of the campaign during Sexual
Oh, they.
Dyspareunia.
Oh, dyspareunia. Dyspareunia, yeah. So,
Dyspareunia.
we wanted.
Let me attempt to spell that.
I do as a nurse practitioner, I don't do it as a regular nurse,
Let's
but
see if I did that
go
right.
over different types of contraception.
Dyspareunia. Oh, I almost right. I was right.
All right, well, we take a break now.
Yes, thank you, Lord.
Get halfway through.